This section of coronary heart disease is simply on the diagnosis. You don't need me to be able to tell you to get an EKG to make a diagnosis of ischemic heart disease. Certainly for all of them, the best initial test is an EKG. Even if you think it's reflux disease, but somebody says, I have substernal pain, you must do the EKG first, because if this person says I have substernal location of pain, I must first exclude the ischemic heart disease before I go on to the other diseases. Now, you should be expecting the EKG to be normal in most cases at the beginning in the office. You should expect that a person who says, hey, I've been having chest pain off and on for the last couple of weeks or months, it's extraordinarily unlikely that you're going to have ST segment elevation or depression now. So you do not have changes on the EKG with chronic problems. But you must get the EKG first in all the chest pain cases, because you can't do the other tests without the EKG. You don't know whether to do a regular stress test or stress thallium. You don't know whether there's a left bundle that makes a stress test unreadable. You can't do the other tests. What if it showed Q waves in an old MI? Then you know there's coronary disease. What if there are other findings that make the EKG unreadable for ischemia? You must do the EKG first, even when you don't think there is real ischemic pain. It is very difficult for a medical student to understand the difference in setting in which the patient is presented. It is very difficult to understand that chronic chest pain or chest pain off and on for a few weeks in an office has a very different management than I have chest pain now and I'm in the emergency department. The hardest thing to learn for a medical student who does not have enough experience is the order in which to do things. And that happens to be exactly what you're tested on. Enzymes are not the answer in office or ambulatory cases. A guy comes to the office and says, hey, doc, I've been having chest pain off and on for the last couple of weeks. This is not the person who you're getting CKMBs now to see whether they had a myocardial infarction today. That's the person who you get a stress test or an echo as an outpatient. You're not doing enzymes in chronic and stable chest pain. Those people should be going to the emergency department. If you have acute chest pain, the answer is you're going to the emergency department now. So office-based cases do not get enzymes. If they have an acute problem, send them to the emergency department. Enzymes are the answer when a patient is acute. I have chest pain now. I'm in the emergency department. It is not clear whether it should be a CKMB or a troponin. What we know is that they both go up after about 4 to 6 hours. They go up at the same time. The CKMB only lasts for 1 to 2 days. The troponin lasts for 1 to 2 weeks. Exercise tolerance testing is used synonymously with the term stress test. A stress test is when the etiology is not clear. If a person has chest pain that is exertional, relieved by rest, and it's a repeated clear pattern, you don't need a stress test. You already know they have ischemic pain. If the EKG shows clear ST segment depression, you don't need a stress test. If the EKG is unclear, you need a stress test. If the history is unclear, you need a stress test. And a stress test, exercise tolerance test, needs you to be able to read the EKG for ischemia. What do you see on that EKG for ischemia? You see ST segment depression. That's how you detect the ischemia on the EKG. You look for ST depression. And you need to be able to exercise. Exercise means being able to get up to 220 minus your age. That's a maximum heart rate. Maximum heart rate is 220 minus your age, but you don't have to get to 100% of it. Even 80% of it is good enough. And that stress test is when the etiology is uncertain, not when it's clear already. Thallium is one form of nuclear isotope. They will not ask you on step 2 to be able to distinguish between the different forms. So if there's different forms, as long as they say nuclear, that's good enough for you. You see, nuclear isotopes are picked up by the sodium-potassium ATPase within the cell because thallium looks like potassium to a myocyte. If that myocardium is alive and perfused, it'll pick it up. If it's ischemic or infarcted, it won't pick it up. If it's infarcted, it'll never pick it up because dead things don't pick up things. If it's ischemic, it will show pickup on reperfusion after rest. Both will show decreased thallium and nuclear uptake, but the ischemic one, when you rest, reperfusion images eventually will pick it up. Like a traffic jam, the cars get through eventually. Now, dobutamine echocardiography looks for the fact that echocardiogram should show the wall moving. Muscles that are alive move. But if it's ischemic or infarcted, it won't move. If it's infarcted, it won't move because dead things don't move. But we don't just say dead things in medicine. We didn't go to medical school to say dead things don't move. So we call it dyskinesis, akinesis, hypokinesis, whatever way you learn to say, hey, it don't move us so good. So a dobutamine echo will show decreased wall motion as a sign of ischemia. If it is ischemia only, on rest, it will start to move again later on after using the drug. The point about ischemia versus infarction on a stress test is critically important, that you understand that ischemia is reversible. The perfusion defect on nuclear will reverse. Eventually it will pick it up. The wall motion abnormality will reverse. If it's ischemic, insufficient perfusion, eventually it will start to move again. It will return to normal after the rest period. However, if it's infarcted, it's irreversible. This fact that irreversible changes on a stress test indicate a dead piece of myocardium cannot be overestimated, because if it says irreversible, you don't catheterize that. There is no point in bypassing or angioplasting to dead tissue. There's no point in bypassing or angioplasting to normal tissue. What you are looking for with the stress test is the reversible changes. That is the number one thing you're looking for. That's the part you can fix because it's ischemic with exercise and normal at rest. That's the number one thing you look for. Reversible changes. In order to be able to do an exercise tolerance test, you have to be able to read the EKG and you have to be able to exercise up to a sufficient heart rate. Well, what happens if you can't exercise and get that heart rate up? We have to use chemicals to simulate the effect of exercise. Persantine or dipridamol will increase perfusion and flow to the heart in a normal person. If it doesn't increase, it's ischemic. And then you should be able to see an increased pickup of the nuclear isotopes, thallium or sestamib or one of the other nuclear isotopes. Or you use dobutamine in combination with the echo. Dobutamine simulates exercise. Dobutamine increases oxygen consumption and should provoke ischemia. Therefore, if you have a decreased wall motion with dobutamine that's reversible, it means it's ischemic. If it's irreversible, it's infarcted. Now, here is a super gunner question. You're the type of person who wants to get a 280. Dipridamol should not be used in patients who have chest pain and asthma because dipridamol is a phosphodiesterase inhibitor. It increases cyclic AMP. Cyclic AMP provokes bronchospasm. Therefore, the high-functioning student will know that in an asthmatic, you should use dobutamine echocardiography or stress thallium, but not dipridamol thallium. Let's summarize our indications for stress tests. For the standard exercise tolerance stress test, we want to be able to simply look for the presence of ischemia. So we're going to put them on a treadmill, run them up to their heart rate, and look for ST depression. Now, an exercise thallium is when you can't read the EKG because you already have ST segment depression. You have a pacemaker or a bundle branch block, or you have digoxin, you have ST segment depression or elevation of baseline, left ventricular hypertrophy, for instance, or it gives baseline ST segment changes. You can't read the EKG, use thallium. Or you can't read the EKG, use an echo. Now, one of the hardest things for people is to understand that exercise thallium and exercise echo are identical in sensitivity and specificity. You cannot be asked to choose between them. They have the same indications, the same sensitivity and specificity. Stress thallium and stress echo are equally accurate. I also want you to notice I use terms accuracy. I don't use terms like gold standard because it doesn't mean that you have to do these tests. They are the most accurate way before you do angiography. Doesn't mean you have to do them. If a regular exercise stress test shows the ischemia, these other tests, exercise thallium and exercise echo, are not necessary. But they are equal in their accuracy. Dipridamol thallium has the same indications as an exercise thallium, except in the person who simply cannot exercise. And you look for a decreased uptake of the nuclear isotope, the same as you would in a stress thallium. And dobutamine echo has the same indication and decreased wall motion, the same findings as you would on a stress echo. It's just in a person who cannot exercise, which is fairly common. Nuclear isotope testing and echocardiography are equal in their sensitivity and specificity. When you're a third-year medical student and you see that the institution you've been rotating through uses one, you may automatically say, well, this is what I see my attendings use, so this one, of course, must be better. But it's not. It's simply a preference. They are equal in their accuracy, sensitivity, and specificity. They are equal in their indications, exercise thallium or exercise echo, chemical thallium or chemical echo. They are exactly equal. They are essentially interchangeable. How we evaluate the patient, in summary, looking at the possibility of coronary heart disease. If the resting EKG has no abnormalities and the patient is able to exercise, we do an exercise tolerance test looking for ST segment depression. Now, if the person can't exercise, then the step here is to chemically simulate that exercise, either with dipyridamol and thallium or dobutamine and echo. In dipyridamol thallium, you will see decreased thallium uptake in response to the chemical. In the case of dobutamine echo, you'll see decreased wall motion if you can't exercise. Now, if there are resting EKG abnormalities, we can't read the EKG for ischemia. We have to do stress echo or nuclear stress test to be able to tell us whether or not somebody is able to have ischemia. So if you have an EKG that's unreadable, then we find a different way to look at the heart with the stress echo or a nuclear stress test. Now, if any of these is positive, the next step is angiography, because angiography is the only way we're going to know. Is this one or two vessel disease that should get a stent, or is this three vessel disease, left main, or two vessel that needs bypass? Three vessel disease of 70% stenosis in each one. Left main with 70%, or two vessels in diabetics get bypassed. The angiogram allows you to know who should be revascularized by knowing the anatomic location of the disease. You can't tell whether it's surgery or angioplasty or another method of removing the plaque, rotablator, diamond blades that actually have diamond tips that rotate at 160,000 revolutions per minute, grinds it out, sort of like going to the dentist, until you do the angiogram. That's the only way you can know whether or not somebody needs to be bypassed. There's no way to know by EKG or by symptoms whether there's three vessel disease or not. No way to know. And that's also why not just use medical therapy, aspirin, statins, beta blocker, ACE, because you can't tell who will live longer with bypass until you do angiography. Narrowings that are less than 50% of diameter are irrelevant. Now, this is hard to understand, that you can have a 30-40% narrowing and it means absolutely nothing. In fact, it's not even terribly clear who should be operated on or get angioplasty until it's 70%. Your question is going to be 100% clear, and 100% clear is they're going to tell you that the person's either going to be 20 or 30%, which is do nothing, or it's over 70%, which is stented or bypass it. Holter monitoring is a test for a completely different indication. One of the things that you're going to do in this class is learn to work backwards from the answers. So let's work backwards from the answers and say, okay, when is Holter monitoring the answer? Holter monitor is an ambulatory version of telemetry. Telemetry is for inpatients, and Holter monitoring is for outpatients. And it records your rhythm, and it does not show ischemia. It does not show ST segment elevation. It can be for 24 hours, up to 48 or 72 hours. Sometimes you have a little clicker on it, and you can actually click, click, click when you have symptoms. That's called an event monitor. Doctor, I'm having an event. Click, click, click. So they can say, okay, what was happening to you when you had those symptoms? Was there actually an arrhythmia? Or were you just feeling anxious? So it detects rhythm disorders and rhythm disorders only. Maybe in 24 hours you only have 5 minutes of AFib. It'll find it. Maybe in 24 hours you have 5 minutes of atrial flutter, or 5 minutes of VTAC, or 20-second runs of these. It will detect it and allow you to zip through at very fast speed and analyze 24 hours of EKG in just a few minutes by having the computer analyze it. This way you can detect short runs of VTAC. The Holter monitor is not for ischemia, not for valves, not for ejection fraction, and it cannot assess whether or not you're having an MI. It's an arrhythmia recording device.
This question looks at a 48-year-old woman who comes to the office with chest pain that's been occurring over the last several weeks. The pain isn't reliably related to exertion. She's comfortable now. The pain is retrosternal. Past medical history and the EKG are normal. What is the most appropriate next step in management? The first thing we have to point out here is that ischemic pain is retrosternal. I'd like to point out that non-ischemic pain, most of the time, is left-sided. Left-sided pain, we should say, is not ischemic. It's under the sternum for normal people. So what's the most appropriate next step in management here? Well, first of all, take a second to look, pause the tape, and just take a second to look at all the choices. Well, what you see is that almost all of these are indicated at some time. Now, this person does not have clear pain. It's also in the office, and she doesn't have pain now. Because she's in the office and she doesn't have pain now, enzymes such as CKMB and troponin are not appropriate. In addition, you would not go first to angiography with someone, not straight from a person who's just in the office with chest pain. The truth is, we're not certain whether this woman has chest pain that is ischemic in nature. Because of that, we should be looking at exercise tolerance test, commonly known as a stress test. The exercise tolerance test is a measure of, is this pain truly ischemic or not? CKMB and troponin levels are only when you have an acute person who is in the emergency department. ACS means an acute coronary syndrome. The echocardiogram looks for valve disease. Valve disease, wall motion, and the EF is the ejection fraction. So at some point it may be that she needs an echocardiogram, but certainly not first. The angiogram is what we'd get if somebody had an abnormal stress test. The angiogram is to determine the anatomic location of a stenosis and determines a method of revascularization. For instance, if it's only one or two vessel disease, we would generally choose angioplasty, percutaneous coronary intervention. If it's three vessel disease or left main, the answer is a cardiac bypass. CT angiography is not quite ready yet, not quite ready for prime time, not quite ready to be used as a routine test. We're not sure what to do. We do know that CT angiogram and high calcium scores are associated with worse disease, for sure. But when to precisely use it is not too clear. Cardiac MRI is also not yet clear what to do with it. The Holter monitor is exclusively to look for rhythm evaluation. The Holter monitor is the answer for when you have a person who has palpitations or syncope, and you go, is there an occult arrhythmia that I don't know, that I can't find with the EKG? I want a more sensitive test for looking for an arrhythmia. Let me get the Holter monitor and monitor them at home for 24 hours to 48 hours and see if they're having an arrhythmia. In this person, the most important thing is to determine is this person having ischemic pain? When the story is not clear, get a stress test.